So yes, in the context of neck, it's bad, and it's probably pretty bad getting some gas in there when you're putting in a UVC. So make sure you flush those lines properly. Hello and welcome back, or welcome for the first time, to Tala Talks NICU, where we take complicated medical concepts and break them down so that you can understand them and hopefully retain them forever. Today we're going to go over part 2 of NEC. So I would highly recommend that you go back and watch part 1, where we talked about the pathophysiology, or what causes NEC, as well as different ways to prevent NEC. Honestly, you'll probably get a lot out of this video even if you don't go and watch the first part, but still it will help that kind of complete knowledge that you really need for the NICU. So today is part 2 of the NEC videos, and today we're going to be going over the diagnosis of NEC. So just like everything else that we do in medicine, today we're going to go over 1, the history, 2, the physical exam, 3, the imaging that you need when you're concerned about NEC, 4, the lab studies and what you need to look for and what you may see if a baby has NEC, and then 5, we'll go over the Bell's staging of NEC. Before I start going through the physical exam and everything, I just wanted to say that we are not very good at diagnosing NEC. There isn't a single test or lab finding or physical exam finding that we can all point at and say, yup, that baby has NEC, or that if they don't have that finding, then we can say, no, the baby doesn't have NEC. And so this has really made it really difficult to study the disease and therefore to prevent and to treat it adequately. So even in the studies and in the literature that's out there, we know that there's probably loads of babies included under the umbrella diagnosis of NEC that may have just had a bad milk protein allergy, or they had a spontaneous intestinal perforation, or they had a septic ileus. So because there isn't exactly one test that we can point at that says that definitely gives the diagnosis of NEC, it has been very difficult overall to diagnose and to study. This has been a topic of heavy debate recently, that how great it would be if we just had one protein or one enzyme that was elevated that we would be able to categorically say that a baby has NEC. Hopefully with all the research that's happening, eventually we will get that. I would like to say though that there is one finding that is considered pathognomonic for NEC. Pathognomonic means that when you see it, you know that a baby or a patient has that disease. So for example, Koplik spots in the mouth are pathognomonic for measles. So the pathognomonic diagnosis in NEC is Pneumatosis intestinalis. So the bubbly appearance that you see on the X-ray, if you see that with the other symptoms, hopefully, then you can say that yes, this is NEC. Right, so let's start with history. So as we've said over and over again, the vast majority of NEC happens in preterm infants. About 10% of NEC happens in term infants. So if you do have a 2-day-old term baby that starts puking green, you're not immediately going to think, oh, well, this must be NEC. You would be thinking that maybe this is a volvulus or a gut atresia or something. Obviously, NEC is on the list, but if you had a preemie baby who was 3 weeks old who started puking green, I would be a lot more concerned. So most NEC does happen in premature babies. And what's interesting is the younger the baby is, the longer it generally takes for them to get NEC. So for example, if a baby was born at 23 weeks, then they might get NEC when they're about 2 months old. Whereas if a baby was born at 29 weeks, they may get NEC at 2 to 3 weeks. This is kind of just generalization. There seems to be a peak incidence of NEC somewhere between the corrected gestational age of 30 to about 33 weeks. So again, going back to the original numbers, if you're 23 weeks and you're a couple of months old, then you're getting pretty close to that stage. If you're 29 weeks and you're a couple of weeks old, then you're going to be within that kind of peak NEC period. So again, if I'm told that a 2-day-old X24 weeker has a lot of green residuals, I'm probably not immediately going to jump towards NEC. Whereas if I'm told that a 2-month-old X24 weeker is having green residuals, I'm going to be a lot more concerned about NEC. The second part of the history that I'd like to know is whether the baby has been fed. As we spoke about in the part 1 videos on NEC, NEC generally does not happen if a baby has never been fed, probably because we need the bacteria and the colonization and everything to build up in the intestine. So if a baby is an X24 weeker, is 5 days old and has never been fed, and the belly suddenly looks huge and distended, I'd be a lot more concerned about a spontaneous intestinal perforation than I would be about necrotizing enterocolitis. And then other parts of the history may be important. As we discussed in the first video, there are other risk factors that may be associated with the development of NEC. So for example, you want to know, did the baby just have a huge increase in the volume of their feeds? Did we just go up on the amount of calories that we give the babies? Did we just have a blood transfusion in the last 48 hours? Does the baby have an absolutely whopping PDA? And I know that you're not doing this in your unit, but has the baby ever been given Zantac? So go back, look through all the history, and does this look like it adds up? And this could be a baby that is at increased risk of NEC. Right, now let's go over the second part, which is the physical exam findings. Again, there is absolutely nothing that you could point at on the physical exam of a baby and say, oh, this baby's definitely got NEC. All of these physical exam findings can be found with other disease processes as well. However, the more of these findings that you have, the higher the likelihood that what the baby does have is NEC. And I know that you do really probably know most of these physical exam findings. Generally, we can divide them into two groups: the physical exam findings and the signs and symptoms that are gut related, and the ones that are not gut related. Let's start with gut issues. So the first one is that you start having increased green residuals, or that the baby's actually vomiting green. The green is, as you know, the bile, which is thrown out from the liver normally into the duodenum. So if there's some sort of blockage, whether it's an anatomical blockage or whether the intestine is no longer moving forward via peristalsis, then instead of that bile moving down the gut, it starts going up into the stomach and then eventually puking it out. So basically, whenever you have a green emesis or green residuals, it means that the gut is not working. This is a potential sign for NEC. The second sign that you may see is a distended abdomen. So really, even if the baby's having a bit of feeding intolerance, which as you all know, we see in the NICU all the time, a lot of times we just kind of let that go as long as the abdomen is nice and soft. So in a normal baby, the abdomen should be soft. So kind of if you push it in, it should be kind of like a pillow. It should give. It shouldn't be hard and tense. Whereas a distended abdomen, especially if it's hard, doesn't have a lot of give. So make sure that you get used to that distinction on physical exams. Sometimes you can have a distended belly that's kind of full of gas, especially if the baby's on CPAP or something, but it's still soft. You can still kind of push it in without the baby grimacing or tensing up, or without it looking like it's tender, which means that the baby's in pain when you touch it. So if the baby has a distended, hard abdomen, then that is concerning. If a baby feels sick, then one of the first things that happens is that peristalsis stops. So the intestines just become boggy and they're not moving forward anymore. So if you listen to the belly through a stethoscope, you won't really hear any bowel sounds. This is also a concerning sign for NEC, or a septic ileus, or another sickness of the gut. If, for example, the baby's belly was distended, but you hear really good bowel sounds, then it's more likely just to be like a CPAP belly. Absence of bowel sounds is concerning for NEC though. Another concerning sign for NEC is that the top of the belly looks red, or actually looks like it could almost have like a cellulitis on it. This is generally a really bad sign. This could indicate that there is peritonitis, so the fluid in the belly cavity, the peritoneal fluid around the intestines, is infected. As you can imagine, this happens most frequently if you actually have dead gut or if you have a perforation. But it can also happen if you just have really, really sick gut in there, which isn't necessarily dead. But generally, the presence of a red belly in NEC is a pretty bad sign. Remember always to roll down the top of the diaper when you're examining a baby's belly. Sometimes that redness could be really low down and you could miss it on an initial exam. Another sign that we can see with NEC is blood in the stools. So sometimes this is the first sign that you see. Just the nurse will suddenly see a stool that's like covered with bright red blood. Sometimes the stool has occult blood in it, which means that there is blood in there, but you can't really see it. Often the baby will start having other signs of NEC before that occult blood becomes gross blood. There are many other conditions that can cause blood in the stools, for example, an anal fissure or if the baby swallowed a bunch of blood. However, if you do see blood in the stools, we should be scared enough about NEC to at least do some sort of further evaluation, even if it's a very good and frequent exam of the baby. So blood in stools is another concerning sign for NEC. So those were kind of all the major gut symptoms. The second set of symptoms are more systemic. So the symptoms that affect the whole body, which are mostly due to the huge inflammatory response. So these types of symptoms we would see really anytime a baby got really sick, whether it's from sepsis or from HIE, a baby would kind of present like this. So on the milder end, a baby could start having a little bit of temperature instabilities, maybe, and usually that would present with a little bit of hypothermia. So remember, if a baby's in an isolette, they won't necessarily show immediately that they're hypothermic. How we'll know about it is that the isolette is now providing more heat than it had been previously. So it could be a bit of temperature instability, maybe slightly more lethargic, baby's not moving as much, maybe slightly increased in apneas and brady's, frequency and severity, maybe needs slightly increased support, whether they're on the cannula or CPAP or even on the vent. So all kind of slight increases in support compared to what the baby was doing previously. As NEC worsens, then all of these symptoms can get a lot worse as well. So baby could start becoming extremely hypotonic. So they're just lying there limp and they're completely unresponsive. Baby could become completely apneic, so is now making no effort to breathe. And also the blood pressure could start falling off. So the baby's going into hypertensive shock. So all of these things are kind of like at the later stages and very concerning stages of NEC. Okay, now let's talk about imaging. So like we said earlier, if you do have a lot of these symptoms and signs, then probably the next thing that you'd want to do is go ahead and get an x-ray. Specifically, we want to get an x-ray of the abdomen. We call x-rays of the abdomen KUBs, which stands for kidney, ureters, bladder, which for me is very funny in neonatology because an x-ray is probably one of the last things that we'd use to image either any of those things. But anyway, we call them very casually KUBs. And if you have any concerning signs and symptoms for NEC, then you should order a KUB. Like we said at the start, there is one finding that you would see on a KUB that is pathognomonic for NEC, and that is pneumatosis intestinalis. And what that is a buildup of gas by the bad bacteria. A lot of this is actually hydrogen gas. And that gas gets trapped either in the walls of the intestine, and then it gives kind of like a train track appearance where you have the edge of the walls on either side of the intestinal walls, it appears white, and then you have like a thin layer of black gas in the middle. So it kind of looks like train tracks. Or the pneumatosis just looks like a really bubbly appearance throughout the intestines. The problem is sometimes we're tricked even with pneumatosis. So if a baby has loads of stool in the gut, then that can kind of look like it's a bubbly appearance. Or if two different intestines were kind of lying on top of each other, then that can kind of also give an artifact where it looks like that there is air inside the wall of one of the intestines. So that is why it's important always to follow serial x-rays. So we'll get an abdominal KUB every 4 to 6 hours to make sure that this is all kind of moving around, or to make sure that the baby's stooled and that there's no longer a gassy appearance. There are two other findings that you see on a KUB that may also kind of make you a little bit concerned about NEC. The first one is just huge distended bowel loops. So a large kind of loop of bowel that seems to be filled with air and is not moving forward. This could be kind of in early NEC where there is no longer peristalsis. So the air's kind of stuck in there and the loop of bowel is not moving forward. Or it could also be a really bad sign later in NEC that piece of bowel is actually dead, and so that's why it's not moving forward. It's just like this sticking in the same place on the KUB. The other finding is that you might see thickened bowel walls. So the normal white walls of the intestine start looking a lot thicker. And this could be a sign that they're just a lot more swollen with a whole inflammatory response, and they're just more edematous and filled with fluid and everything else. So 2 other signs that you would look for on a KUB. Another very concerning sign for NEC is something called portal venous gas. And every time you get a KUB, you should be looking for this because it's kind of easy to miss if you're not looking for it. And that is where you end up with gas within the biliary system. So it kind of takes the shape of the bile tracts within the liver, and it just looks like this kind of black tree within the whiteness of the liver. Seeing portal venous gas is generally a really bad sign. We actually used to think that it was a reason for a baby needing surgery, but now we know that that isn't the case. But generally, it's a pretty ominous sign for bad NEC if you are seeing portal venous gas. So make sure that you look for it. As an aside, portal venous gas is not actually pathognomonic for NEC. If you accidentally put a little bit of gas in your UVC as you're threading the UVC, that can also end up within the biliary tree, and that can look like portal venous gas. So yes, in the context of NEC, it's bad, and it's probably pretty bad getting some gas in there when you're putting in a UVC. So make sure you flush those lines properly. Another bad sign is a gray gasless belly on the KUB. So you get the KUB and all it looks like is just grayness everywhere. You can't tell, you can't figure out if there are any intestines in there. You can't really say anything about the anatomy of the gut. All you can see is just grayness throughout the whole belly cavity. So this can be a very bad sign that the whole gut is sick and that a lot of the gut could be dead, obviously, if you have the other signs and symptoms. But it could also be kind of early NEC or some sort of ileus where the gut is just not moving forward. You generally, even if you're not worried about NEC, you should not really be feeding a gray gasless abdomen. Then ultimately, the reason why you want to get serial KUBs, and it could start at every 4 to 6 hours, and then we could stretch it out to 12 hours or Q day, but is you want to, first of all, follow the gut pattern and see if those loops are moving around, if that really is stool, if there is pneumatosis that's gone away. But also you want to see if there is going to be a perforation. So if that gut gets really sick and dies, then air from within the intestine escapes through the intestinal wall and goes into the peritoneum, therefore causing a pneumoperitoneum. So you are looking for free air on those KUBs. Sometimes it's really obvious, and even by looking at a regular AP, so just a flat KUB, you can tell that there is free air and there's huge amounts of black air within the belly cavity. Sometimes the free air is a lot more subtle, and in those cases, the best way to kind of tease out whether a baby does have free air or not is to get a left lateral decubitus. So that is where you lay the baby down on the left side so that the liver, which is on the right side of the belly, so is on the right side up. So if there is free air, then the air will rise up and get trapped under the liver. Because the liver is a nice white solid organ, the black air, the black line of air will be a lot more obvious when it rises to the top and gets trapped under the liver. So with any concerns whether a baby has a pneumoperitoneum, not just with NEC, but with anything, then go get a left lateral decubitus x-ray. So in summary, these are all the different findings that we can see of NEC on a KUB. So we can have distended bowel loops, thickened intestinal walls, pneumatosis intestinalis, which can look like the bubbly appearance, or it can look like kind of the train tracks. We can have portal venous gas, we can have a gasless abdomen, and we can have pneumoperitoneum, where we actually have free air within the belly. Now let's talk about the lab findings in NEC. Like a lot of what I've said already, a lot of these lab findings are very non-specific and really not that sensitive. But in combination with all the other findings, you do become a lot more concerned for NEC. So the first thing is, anytime a baby acts up at all, whether a few more A's and B's, increased oxygen support, kind of looks a little lethargic, then obviously you're going to be sending a CBC and a blood culture because if nothing else, you're worried about sepsis. So on the CBC, and go back and look at the early CBC videos that we did right when we started this channel, because we kind of went into this more, the things that you're most worried about are kind of a suppression of the bone marrow. So I would be more concerned about NEC if I saw leukopenia, so a WBC count of less than 5,000, if I saw neutropenia, so an ANC or an absolute neutrophil count of less than 1,500, as well as thrombocytopenia. And thrombocytopenia is really common in babies with NEC. In fact, about 50% of babies with NEC will end up with a platelet count of less than 50,000. But as you all know, we consider thrombocytopenia as less than 150,000. The blood culture will be positive in about 20% of babies with NEC. By the way, 20% is a really good number to just learn in babies with NEC. About 20% of them have a positive blood culture, about 20% of babies will end up needing surgery, and there's about a 20% mortality from NEC. So remember the number 20%. When the baby does have a positive blood culture, we're never really sure whether it's cause or effect. If a baby does have a bacteremia and is septic, they are more likely to end up getting a sick gut and end up being diagnosed with necrotizing enterocolitis. But also, if a baby does have NEC, then their gut becomes really leaky, and there's a much higher chance that the bacteria that were previously hanging out in the gut can kind of get in to the blood and cause a bacteremia. If you get a gas in an infant with NEC, then you're going to see three things. So the first one would be a respiratory acidosis. So because the baby isn't taking deep breaths or the baby is apneic, then the baby will start building up the carbon dioxide and you'll end up with hypercarbia or a respiratory acidosis. The second thing that you would see is a metabolic acidosis. So if the baby does have NEC, then we are probably starting to produce a lot more lactic acid. So there will be a buildup of lactic acid, and therefore you will have a low bicarb and you will have a larger base deficit. And then the third thing is, obviously, if you have both a respiratory acidosis as well as a metabolic acidosis, then there's a good chance that you're going to see a much lower pH. So a pH of less than 7.20 with all these other symptoms going on is concerning. If you get a chemistry panel or a basic metabolic panel, whatever you call it in your institution, then there are some other pretty non-specific findings that you may see. One of the most common ones is hyponatremia, or a low sodium. And that's normally kind of a combination of things. Normally, there's so much leakage of sodium and fluid everywhere in the body that there's just less sodium in the blood. That also isn't helped by the fact that generally sick babies start peeing a lot less, and so there's just a fluid accumulation as well. So hyponatremia is pretty common in NEC. The other thing that you would see, like we talked about earlier, is a low bicarbonate. This again would go with a whole metabolic acidosis. If the baby is peeing a lot less, then the creatinine might creep up. And then if there really is dead gut or there is a lot of acidosis, then you could see hyperkalemia. So when most of the potassium is in cells, so if the cells die and that potassium is released, then you are going to end up with a high potassium in the blood. If you consistently have a hyperkalemia or high potassium, then that is very concerning that there is dead gut in there that somebody needs to go in and get out. There are obviously other lab tests that have a high chance of being abnormal as well. If you're going into flat out DIC, then you could end up with a high PT and a high PTT and a low fibrinogen. How many of these lab findings you have, how severe they are, and also how long they last could really be indicative of how bad your NEC is. So for example, say you had a baby with NEC and you're treating them medically and nothing on the x-ray ever really looks like they need surgery. There isn't kind of like a fixed gut loop or there isn't obvious pneumoperitoneum. But say that your platelets stay low no matter how many transfusions you're giving, or there's a persistent acidosis, or the potassium is staying on the higher side, then putting all these together, there's a much higher chance that there really is dead gut in there that needs to be surgically eliminated. Now let's talk about Bell's staging criteria. So in the 1970s, Bell set up this system of classification of NEC and divided it into 3 different stages. This has been immensely useful in the studying of NEC, as well as obviously categorizing NEC, although there have been a lot of modifications since then, and I'll talk about that in a second. But essentially, the 3 stages of NEC are: 1, the stage 1 NEC is kind of that rule out NEC, where maybe baby had like a bloody stool or had a bit of abdominal distension, maybe some bad feeding intolerance or a green residual, but nothing on the x-ray that actually flat out diagnosed NEC. So no portal venous gas and no pneumatosis. These are kind of like those rule out NECs that we see a lot in the unit. Stage 2 NEC is the NEC that's actually definitely diagnosed as NEC. So those are the NECs that we see pneumatosis in, or portal venous gas, in addition to other signs and symptoms. So we would also see the bloody stools and the green residuals, maybe the distended abdomen, maybe babies having more A's and B's. When NEC is studied in literature, then generally it's only stage 2 and stage 3 NEC that's included, because you can imagine a lot of that stage 1 NEC may just be something else. It could be a clinical sepsis or a milk protein allergy or something else. Stage 3 NEC is surgical NEC. So for whatever reason, whether they saw a pneumoperitoneum or whether there looked like there was a dead gut or there was just persistent thrombocytopenia and acidosis and hypertension, then surgery did need to be done. So 1, 2, and 3 NEC. Obviously, as the stages go up, then the NEC is getting worse. So to summarize that again, and like I said, there have been a lot of modifications from then, and different things have been included or not included in the 3 stages, but we still roughly use them. So it was pretty brilliant that Dr. Bell did this in 1978. So stage 1 is that kind of rule out NEC. We aren't 100% convinced it's NEC, but we're worried enough to do something about it. Stage 2 is definitive NEC, but it's medical NEC. We're still treating it medically. And stage 3 is surgical NEC. Right, so that was everything that you needed to know, hopefully, about the diagnosis of NEC. I hope that you learned something, so please remember to like and to subscribe and leave any requests for future videos below. And please stay tuned for the last video that we have on NEC, which is on the treatment of NEC as well as the general outcomes. Thank you so much for being here.